Welcome to this video on how to manage a critically bleeding patient at Concord Hospital. When a patient is bleeding, usually there are senior team members present, but it's important for everyone to understand what critical bleeding means and what they can do to ensure patients receive care as soon as possible. Often these situations develop very fast and your help can be life-saving. At Concord Hospital, we use the Massive Transfusion Protocol, or MTP, to treat critically bleeding patients. To be considered as critical bleeding and to meet the criteria for activating the MTP, the patient is expected to need more than 4 units of packed red blood cells in 4 hours. They may be hemodynamically unstable from blood loss, and this may be from trauma to the thorax, abdomen, pelvis or long bones, burns or major gastrointestinal or surgical bleeding. It is important to understand that when a patient is bleeding, they are losing red blood cells, but they are also losing or consuming other elements of their blood that help their blood to clot. Treating critical bleeding not only requires transfusion of packed red blood cells, but also the replacement of these elements in the patient's coagulation system. This may involve transfusing platelets, extended life plasma, and cryoprecipitate. We call these other elements yellow products. Extended life plasma is like fresh frozen plasma, but has a longer shelf life once thawed. Both extended life plasma and cryoprecipitate take 30 minutes to thaw, so it is important to notify the blood bank early. Before we delve too deeply into the MTP, there are some physiological targets that we should prioritize early to optimize functioning of the coagulation system. By virtue of having activated the MTP, we should consider giving tranexamic acid to reduce clot breakdown in a critically bleeding patient. Establish large bore venous access to prepare for infusion of large volumes of blood products. Be proactive in maintaining normal temperature and calcium and preventing acidosis as much as possible. Once a senior clinician determines that the patient meets the criteria for activating the MTP, either they or their delegate should call the blood bank on 76972 or 76686, who will start preparing blood products as quickly as possible. The blood bank will prepare MTP Pack 1, which contains 4 units of packed red blood cells and 2 units of extended life plasma. You must complete the blood product issue form and give it to the porter each time you want to collect an MTP pack from the blood bank. You should affix the patient label, simply write MTP, and the name of the ordering clinician. As certain blood products need to be thawed and take longer to prepare, sometimes the blood bank will dispense part of the MTP pack with the components that are ready. The blood bank will notify you once the remaining components are ready, and you should send another blood product issue form with the porter to pick up the remainder of the MTP pack. In the interim, we should also collect a set of baseline bloods from the patient. Remember to collect the blood from a site without an infusion running, or if you have no other option, pause the infusion for 3 to 5 minutes first. Do not delay transfusion of blood products whilst waiting for these results to come back. These blood tests should be repeated every 30 to 60 minutes as the MTP progresses. You should also contact the Hematology Advanced trainee if you activate the MTP. This enables a multidisciplinary approach to resuscitating the critically bleeding patient. The contents of the MTP packs are standardized. After dispensing MTP Pack 1, the blood bank will prepare MTP Pack 2, which contains 4 units of packed red blood cells, 4 units of extended life plasma, 3 units of cryoprecipitate, and 1 unit of platelets. Once MTP Pack 2 is dispensed, the blood bank will prepare MTP Pack 3, which contains 4 units of packed red blood cells, 4 units of extended life plasma, and 3 units of cryoprecipitate. You should also consider giving tranexamic acid to reduce clot breakdown in a critically bleeding patient if not already administered. This is particularly helpful in trauma patients. Subsequent MTP packs dispensed by the blood bank will alternate between Pack 2 and Pack 3. When bleeding is controlled and no further blood products are required, you should call the blood bank to stand down the MTP and return any unused products. This is a picture of a ROTEM machine. ROTEM is a diagnostic assay which complements the traditional coagulation assays like APTT, PT, and fibrinogen count, and uses a sample of the patient's whole blood to assess in real time how the different elements of their coagulation system are interacting with each other. In a critically bleeding patient, ROTEM is available at Concord Hospital at any time of day and may be useful in determining which yellow products and in what quantities are required for that particular patient. It is important to note that the default pathway for managing critically bleeding patients at Concord Hospital is activation of the MTP and standardized MTP packs. However, ROTEM may be utilized at the discretion of the senior clinician in consultation with the hematology advanced trainee if there is strong suspicion of coagulopathy, such as a patient who has ongoing uncontrolled bleeding despite multiple MTP packs being transfused. In addition, ROTEM may be useful in certain patient subsets, like burns and heart failure patients, where transfusion of excessive extended life plasma places them at high risk of ARDS and fluid overload, respectively. In cases where ROTEM is concurrently being utilized during activation of the MTP, the blood bank will continue preparing the standardized MTP packs. However, the senior clinician may decide, based on ROTEM and in consultation with the hematology advanced trainee, to order additional yellow products in specific quantities from the blood bank. To obtain these additional products, you should complete the blood product issue form and affix the patient label, write down the specific type of blood product and quantity, write the word ROTEM, and the name of the ordering clinician. The hematology advanced trainee will liaise with the blood bank to confirm that additional blood products are required based on ROTEM, and that they should be prepared concurrently with the standardized MTP packs. Where ROTEM is used out of hours, the on-call hematologist will also be available to advise a hematology advanced trainee. In other clinical situations, the senior clinician may determine from ROTEM that certain yellow products which are included in the standardized MTP packs can safely be omitted during resuscitation of that bleeding patient. In general, the senior clinician utilizing ROTEM to guide their transfusion strategy will come from a critical care background and have extensive experience in ROTEM. They will also be discussing closely with the hematology advanced trainee to make these clinical decisions. At Concord Hospital, the ROTEM machine is located in the hematology lab on the ground floor. This is the protocol for how to obtain a ROTEM test for a critically bleeding patient and how to access the results. In summary, you should collect a sample of the patient's blood in a blue top citrate tube correctly filled to the line. You should fill out the pathology request form, affix the patient label and write ROTEM do not spin and the clinician's name and contact number and send these to the lab. It's important to call specimen reception at 76663 in hours or hematology lab directly at 76686 out of hours to inform them that the sample is coming so that they can turn on the ROTEM machine. The initial results from the ROTEM assay are available within 10 minutes and should be reviewed in real time by logging onto the ROTEM portal from any hospital computer. A laminated version of this flowchart is accessible in the operating theatres, intensive care unit and resuscitation bays in the emergency department, so you do not need to memorize the URL, login and password to access the ROTEM portal. Now let's talk about how ROTEM can be used to guide transfusion of blood products in the critically bleeding patient. These are the graphs that the ROTEM machine produces. They provide a visual representation of the patient's ability to form a clot, now called temograms. Firstly, the temograms show the time for clot to start forming, and this is called the CT or clotting time. We can also measure the strength of the clot from the amplitude or thickness of the curves. This is measured in millimeters, and we look at the A5 or amplitude at 5 minutes. We can also look for unstable clot. The ml or maximum lysis represents how quickly the clot breaks down over time. The 4 temograms measure different aspects of the coagulation system. Different reagents are added to the patient's blood by the machine so that we can look at these different aspects. XTEM is a measure of the extrinsic clotting system and can be thought of as similar to INR. INTEM is a measure of the intrinsic system and is similar to APTT. FibTEM tells us about fibrinogen levels and is similar to fibrinogen count. HepTEM detects heparin-related coagulation disturbances and is relevant in patients who have received large doses of heparin, such as during cardiac or vascular surgery. When using ROTEM to guide transfusion in the critically bleeding patient, you should refer to the ROTEM interpretation algorithm, which is also accessible in the operating theatres, intensive care unit, and resuscitation bays in the emergency department. The algorithm prompts you to look at specific parameters from the temograms, such as XTEM A5, FibTEM A5, and XTEM CT, to determine if there is a problem with specific components of the patient's coagulation system. A key aspect of the design of the algorithm is that if there is a problem, you stop and fix it with the appropriate treatment, then repeat the ROTEM assay. You will frequently find that correction of issues identified early in the algorithm may improve apparently deranged parameters further down the decision tree. In other words, don't look down the pathway and don't correct multiple factors at once. Now let's use a clinical example to illustrate how the algorithm works. Sarah is a 25-year-old woman who is brought by ambulance to the emergency department following a car accident. She is pale, drowsy, tachycardic and hypotensive. Her fast scan shows significant abdominal bleeding and she is taken to the operating theatre. The anaesthetist activates the MTP as Sarah is critically bleeding and the blood bank starts preparing the standardized MTP packs. The anaesthetist also decides to perform a ROTEM, and here you can see the XTEM and FibTEM temograms. From this, we can see that Sarah's XTEM A5 is very low at 21 mm, and this is below the treatment threshold of 35 mm, according to the ROTEM interpretation algorithm. Her FibTEM A5 is also very low at 3 mm, and this is below the treatment threshold of 12 mm. Her XTEM CT is prolonged at 118 seconds, and this is above the treatment threshold of 90 seconds. In the table, the target values for each parameter are highlighted in green and indicate the point at which a particular component of the coagulation system is considered to be adequate or effective. Now let's look at the algorithm to see how we should interpret these results. In the operating theatre, the anaesthetist will already be addressing Sarah's physiological variables and aim to maintain normothermia, normal acid-base balance, and normocalcemia. And as Sarah has clinically significant bleeding, we can proceed with the ROTEM interpretation algorithm. The first step of the algorithm looks at the XTEM A5. If the number is less than 35 mm, this suggests that there is hyperfibrinolysis or excessive clot breakdown. This should be treated with tranexamic acid. As Sarah is a trauma patient for whom the MTP has been activated, we would hope that tranexamic acid has already been administered. Sarah's XTEM A5 is only 21 mm, and the algorithm prompts us to give tranexamic acid if this has been overlooked. We then move to the next step of the algorithm, which looks at FibTEM A5 and the contribution of fibrinogen to clotting. In many cases, especially trauma, fibrinogen is low because it has been consumed by the coagulation system. If the FibTEM A5 is less than 12 mm, fibrinogen is low and should be replaced. The lower the number, the more fibrinogen the patient needs. In this case, Sarah's FibTEM A5 is 3 mm, which is very low. She needs 6 units of cryoprecipitate to replace her consumed fibrinogen. According to the MTP, cryoprecipitate is only dispensed from MTP Pack 2 onwards. MTP Pack 2 only contains 3 units of cryoprecipitate. In this example, the anaesthetist should discuss with the hematology advanced trainee and ask the blood bank to thaw and dispense 6 units of cryoprecipitate as soon as possible, based on the ROTEM results. Given that we have identified a problem, we need to stop and treat this. Although we recognize that Sarah's XTEM CT result is deranged, we should give her 6 units of cryoprecipitate, repeat the ROTEM, and go back to the top of the algorithm. 10 minutes later, we repeat Sarah's ROTEM. As you can see, the XTEM and FibTEM temograms are much thicker in shape. Often, when you fix one component of the coagulation system, in this case by giving fibrinogen, other measures will improve as the whole clotting cascade works better. This is why it's important to use the algorithm in a stepwise approach. We can see that Sarah's XTEM A5 has improved to 59 mm, her FibTEM A5 is 23 mm, and her XTEM CT is 51 seconds. All of these parameters are in the green zone and within normal range, indicating that Sarah's blood no longer shows signs of abnormal clotting. At this point, Sarah has become much more hemodynamically stable, and the anaesthetist calls the blood bank to deactivate the MTP. They should return any unused components from the MTP packs to the blood bank. From this example, we can see that extended life plasma can safely be emitted from our transfusion strategy for Sarah's critical bleeding based on the information provided by ROTEM. To summarize, at Concord Hospital, we use MTP to treat critically bleeding patients who meet the activation criteria. To activate the MTP, call the blood bank at 76972 or 76686 who will prepare and dispense MTP packs which contain standardized blood products. As the situation evolves, senior clinicians who are ROTEM trained, generally from critical care backgrounds including anesthesia, intensive care and emergency medicine, may utilize ROTEM concurrently to guide transfusion of yellow products. The results from ROTEM are interpreted in the context of the ROTEM algorithm. ROTEM is particularly useful in patients where there are clear indications of coagulopathy and in certain patient subsets like burns and heart failure patients. When bleeding is controlled and you want to stand down the MTP, remember to notify blood bank. In certain situations, a senior clinician may decide to use ROTEM to guide their transfusion strategy in a bleeding patient, even if they do not yet meet the threshold for activating the MTP. We hope this has been helpful and that you enjoy your time at Concord Hospital.